Hello, everyone. This is Dr. Tony Scuderi. I'd like to welcome you again to class. This Zoom is going to be on treatment planning and effective treatment planning and how to do it. You have a pretty good lineup of material for your course. However, I want to bring this down to the clinical level for you. There are several things that you have to be concerned with when doing a treatment plan. First of all, be aware of the company policies. Number one, on when they're due or what you have to do. Treatment plans are extremely important. That's going to govern your treatment for the patient. They're to be comprehensive, yet simple. They're to be directive, yet time limited. And there are several other elements that I'm going to discuss in this. So, whatever the policy is of your company, you got to pay attention to that. The next thing you got to be aware of is the insurance companies. Nobody likes to deal with them. I know I certainly don't. But for each insurance company, they may have a different criteria. Now, if your agency that you're dealing with is strictly Medi-Cal, um, they're pretty straightforward. Other insurance agencies may have a different criteria. So I'm going to talk to you a little bit about Medi-Cal criteria for your treatment plans. Now, when does treatment planning start? Treatment planning starts on day one. Not treatment planning starts when the person walks in the office, day one. You may sit there and say, well, you don't have any information on them. You're right, you don't. But the person is coming in as a patient. You need to have the mindset that the moment somebody walks in the door, a treatment plan has to be made. That's your buts. Okay. That's number one. Number two, with treatment plans, you are learning in this class how to do um, your 12 core functions. One of your 12 core functions deals with what's known as a biopsychosocial, or what we call the psychosocial. Okay. So you have your biopsychosocial, followed by your treatment plan, followed by your treatment. These are also critical elements. So let me start talking to you about treatment planning. Patient's going to come to you with issues and problems. When they walk into the office, don't expect them to be totally cognizant of what they're coming to see you for. Some patients will come in high. Some patients will come in intoxicated. Some patients will come in psychotic. Some patients will come in with other psychopathologies, depression, anxiety, whatever it may be. You don't know what you're going to get, but they're going to be in front of you. Now, here's where the sticky wicket comes in. Can you do an effective biopsychosocial on somebody that you see in front of you that is high as a kite? The answer is no, you cannot. That may be a problem with your agency. This is why I say, number one, check with your agency policies. Because you may have to sit there and do a psychosocial with somebody that's high. You're not going to get a very accurate psychosocial. What you're going to get is something that's happening to them in the moment, which is good. It's helpful because at least you see the patient in their worst, right? Document it. And I want to teach you how to document in a moment. Document. Okay. That's going to be very important. So once the patient is in front of you, let's just say that they're not high or drunk or anything like that. You have this large piece of paper, several pages in front of you. It's called a biopsychosocial. What it is a record that takes a history of the patient. It takes a biological history, it takes a family history, the social history, addiction history, medical history, prison history, everything about the patient. It's a bunch of questions and a bunch of answers. And that's a problem with these documents. You can sit there with a patient and you can Ask the questions, get the answer, write them down, ask the next question, write the answer, go along like that. Personally, I don't like that because that seems like the Spanish Inquisition, right? You're asking a question and you're looking for. When you do a biopsychosocial, you have the document in front of you. First thing you want to do is you want to learn what that document says. So get a blank one and read it. Don't do your first biopsychosocial in front of a supervisor or in front of a person, a staff person that the supervisor put you with. You walk in, ask the supervisor, can you see which documents you need? Can I have a blank chart? And look at the blank chart. Look at all of the intake paperwork that you have to do. And look at all the other documents that you have to do, right? Learn them, look at them. The last thing a clinical director wants to be bothered with is you asking 1,001 questions when it's right in front of you, because you're going to get the answer. Well, it's right there. Read it. And then if you have a supervisor or somebody that's walking you through the paperwork, if they don't sit there and say, here's a blank chart, look at it first. We'll have another meeting after you're done. Ask me some questions, and then we're going to go over all the paperwork. If you just take that chart and stick it in your desk because you're so excited to have a job, that's a problem. Take the chart, read it. It's going to be blank, but read it. Read everything in it. And try to comprehend and understand exactly what that paperwork is asking. What's the release of information asking? How is it structured? How's it set up? The different documents, the treatment documents, what are they saying? The financial documents, what are they saying? What are they asking the patient? Does the patient understand this? A patient should never sign any document without reading it or fully understanding it. We all do it. Have you ever gotten an app on your cell phone, or have you ever gone to something online and your whatever credit card or something, and they sit there and they ask you the question, have you read the legal policy? And you just click it yes, and you move on. You've never read it, and then all of a sudden down the road you find out you owe the money, and you think you cancel it, and they sit there and say, "Oh no, you're under contract." No, but I don't like your service. I don't care. You're under contract. Didn't you read the policy that you signed? What policy? Same thing happens in treatment. All right, patient needs to know everything that they are signing. So therefore, if a patient comes to you and you have to challenge that patient, or you have to bring something to that patient's attention, that patient can't sit there and say, "You never told me," or "What am I signing?" Right? Please make sure you understand the paperwork material. All right. So the biopsychosocial, very important document. Have a conversation with the patient. This is part of what you need to do to join with the patient. And a good source of that is the biopsychosocial. It's a lot of questions, a lot of material, a lot of details. It is not a psychotherapy session. And I want to reinforce that. It is not a psychotherapy session. When you do the biopsychosocial, do not have a psychotherapy session with the patient. A lot of things are going to come up for the patient, as they should. Have a piece of paper with you. Document what the patient is saying outside of the questions so that you have that. And at the end of biopsychosocial, when you write your summary statement, put that stuff in the summary statement. Okay? So when you begin the psychosocial, you want to tell the patient, hello, Mr. Jones. I'm Dr. Scuderi. Nice to meet you. Welcome to the session. I understand that you're having some issues. Real briefly, can you tell me what brings you here today? You're not writing anything at this point. So the person will talk to you, and you sit there maybe a minute or two and say, "Thank you. I think I get a handle on this." Well, here's how we're going to help you, sir. Um, I'm going to have this large document here in your chart. It's called a biopsychosocial. It's a very comprehensive document that is going to give me a lot of information on you. Some of this information is going to be very, very sensitive. It's going to touch on things like maybe abuse. I don't know anything about you yet, but I'm going to need that information. May touch upon certain things about human sexuality, some very personal stuff. It's going to talk about your relationships with family members and friends, and a whole bunch of other stuff, medical, if you've ever been in the military, prison, whatever the case may be, in your substance abuse history. All right. As you can see, it's rather lengthy. It's going to take us some time to complete. Now, there's a couple things I want to ask you. First of all, I want you to understand this is not a therapy session. That happens after this. This is just an information gathering session. Okay? I want to ask you questions and I want you to be as honest as you can. You think you can do that for me? Great. Thank you. I also want you to know that everything that you tell me is going to be confidential. What you tell me goes in this chart and nobody sees it except myself, my supervisor, and if we're in clinical meetings, I may share some material with our clinical staff, and that's it, right? For example, if I'm absent a day, if I'm sick or something, and another therapist takes over and you're in for a session, that therapist needs to know what they're about. They'll have my notes in my chart. But that's it. If the insurance company wants anything, they need to release some information, as you signed off for people in our agency to see this. If anybody else needs it, a release of information needs to be signed, and you need to tell me exactly what you want me to show these people. If not, you don't exist. Is that clear? Thank you. Now, the last thing before we start the psychosocial is this. As I said, there's going to be some sensitive information in here. If it gets to be a little bit too sensitive, right, I want you to try the best you can to answer the questions. But if you can't, let me know. I'll move on to the next section. And at the end, I'll come back, okay, to give you some time. But I need as much information as you can. Understood? Good. Now, as I said about the sensitive information, and this is not a psychotherapy session, please do not feel hurt if I stop you as you're giving me information. Right? I may sit there and say, "Thank you very much. Let me just stop you right there. I understand this is the situation. Can we move on?" Right? And the reason why I'm going to do that is because, as I said, this is a very thick document. And this is not a psychotherapy session, but I'm going to make a notation of it here. And as I make the notation of it, when we do your treatment plan, that's going to go in your treatment plan. Does that make sense to you? Excellent. Okay, can we start? Let's start your biopsychosocial. All right. Now, at that point, it seems a bit lengthy, right? That material is critical. It puts you right out front in front of the patient. It tells the patient what you're going to do, how you're going to do it, and why you're going to do it. And it also protects the patient. It lowers the anxiety of the patient because you're going to be asking some very sensitive material in the biopsychosocial, right? You did the patient um, format on in week one of this class. You know exactly what I'm talking about. Okay? All right. So have a conversation, right? Ask the questions. So tell me a little bit about your family. What's your mother's name? Put the mother's name down. Father's name? How many brothers and sisters? Can I have their names and their ages? So there's Billy, age 32. How'd you get along with Billy, by the way? Was it all right or not all right? Pen, paper, write it down. Any other siblings? Oh, you got Sarah. Sarah's your sister. You older or younger than you? Oh, how many years? How old is she? Okay, great. What was your relationship like with her? How is Billy and Sarah's relationship? What did that look like? Oh, I see. I see. So you guys got along pretty well together? Is that what happened? Oh, I understand that. All right. Toby wants to come up. So so that's good. And how did you guys get along in the family system? Your mom and dad. Sounds to me like you and your mom had some issues. What were they about? Right. See what I'm doing? I'm having a conversation, asking questions, but I'm also having a conversation. That's very important in joining again with the patient. So you get all that stuff done, you get all the information done. Now, depending on your clinic, you have between 1 and 3 days to do this. Your session is usually, again, depending on the policies. I mean, I've been in clinics where we had 3 sessions and you can only do 1 hour session each time. So you start the psychosocial, hours up, you got to stop it. You come back the next day, you do the next part, until it's finished, up to 3 sessions. After that, you're out of compliance, and then there's issues. At other clinics, a 90-minute session. They can have 1 or 2 90-minute sessions. Okay. Um, a biopsychosocial, once you get used to it, it shouldn't take you any more than maybe an hour and a half, 2 hours to do. You got to move through it. All right. So let me just recoup that. So you got the document, you talk to the patient in the beginning, you introduce yourself, you have the patient introduce themselves to you. You give them the parameters of what's going to happen in the biopsychosocial, how that's going to work, why it's going to work that way, and why it's needed. You talk about confidentiality. This is where you bring in things like HIPAA, where you bring in things like 42 CFR Part 2, all of that stuff. FERPA, you bring that stuff in briefly, right? Because they're going to be signing these documents. So if in the beginning, when they come in, you check the documents and you make sure that they signed all of these. Because they'll sit there and they say to you, what's HIPAA? And you've got a HIPAA document in there that's not signed. You need to ask them, have you signed? The intake person, if you're not the intake person, talk to you about HIPAA and FERPA? No? Oh, 42 CFR? No? Well, let me see. You go in the chart and you look, oh, they didn't talk to you about it. You got to do that first. Right? So all that paperwork is done, then you do your biopsychosocial information gathering. Make sure you tell them it's not a therapy session. Make sure that you tell them everything is done. Okay, session is done. This is where your work begins. Once you've done that, you take the biopsychosocial without the patient in there, and you review it. I don't care if you got another patient coming in. At the end of the day, you should review all of the biopsychosocials that you did that day. Right? And you make sure you tell your clinical directors or your supervisor that's what you'd like to do. Because you're going to be required to do a biopsychosocial, and then you're going to have to do a summary of the biopsychosocial. Your summary has to be dead on. It has to be spot on. So read your biopsychosocials over and then summarize it. Start from the first thing and go down. A patient is a 32-year-old African-American male residing in San Francisco, California, et cetera, et cetera, et cetera, and you go down from there. All right. How do you write a summary note? How do you write any note? How do you write your treatment plans? All right. In elementary school, grade school, you learn basic grammar, right? First person, second person, third person, right? Singular and plural. I, you, he, she, it, we, you, they, right? Your basic. When you first person singular is I, second person is you, third person is he, she, right? I, you, he, she, it. First person plural, we. Second person plural, you. Third person plural, they. I, you, he, she, it, we, you, they. All right, very important. You may sit there and say, Doc, come on, will you? No. Because every time I pick up these things, I see, either in the papers that students write, treatment plans, or progress notes that I read, they'll always say I or what I want to do, the patient and me. No. You write in what's known as the third person. This is critical. Insurance companies are known to kick back progress notes and treatment plans. And if there's an inspector that comes in, and you will be inspected, sometimes you get one that's pretty nasty. They'll kick it back also and fail the chart because of that. You never write in the first person, I or me, something like that. Write in the third person. This therapist, this counselor, this patient. Counselor and patient decided on this. Now you can say, and we, that's fine. Keep your name out of it. Keep the patient's name out of it. Except maybe if you want to introduce the patient in the first paragraph. This patient John S. is a blank, 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 32-year-old person. During the session, this patient talked about, not Mr. Jones talked about, this patient talked about. Keep it always third person. That's a professional writing style. It's a clinical writing style, and it's pretty much a mandatory writing style. All right? If you have any questions on that, drop me an email, anthony.scuderi at intercoast.edu, or give me a call at the information on your dashboard, and I will be more than happy to discuss it. Okay? Because that's going to be critical. So your psychosocial is done. You're doing your summary note. Write it in the third person. Start from the first part of your psychosocial, go all the way down to the end. Should be a page or two, right? You don't want to write a 5-page book because you're summarizing it. What is in the summary? The summary has the key points. And at the end of the summary, the conclusion of the summary should be something like, as this therapist concludes this summary, the following items shall be on the or will be on the treatment plan, and now you can bullet point it. Boom, 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 boom. Right? That's going to be good. Sign it off with your full name and your credentials. John Smith, comma, RADT. Right? That's the credential that you'll have at the end of this program when you're done intercoast, right? RADT, registered alcohol and drug technician. Maybe level 1, maybe level 2, probably level 1. If you're a counselor already and you're CADAC 1, it's John Smith, comma, CAC-1. My case, it would be Dr. Tony Scuderi, comma, LAADC-S, licensed advanced alcohol drug counselor supervisor. Right? Whatever it is, you've got to put your name and your credential on all of the documents. Okay? In the event that you're not certified, your technician credential is a registration. It is not a certification. So you have to be supervised throughout your period of you being an RADT, from your internship until you get your CADAC 1. Once CADAC 1, you may or may not, again, according to policy, be supervised or have a supervisor sign you off. Always be supervised. Supervisors need supervision. That's why I'm a LAADC-S. I supervise supervisors. Okay. And I get supervision if I need it from a psychiatrist. Okay. That's just my preference. I can get supervision from another LAADC-S, but I choose a psychiatrist because of my psychological background and all that. That's another story. So you're done your psychosocial, you're done your summary note on it, and now it comes time for the treatment plan. Here is where clinicians really mess up. And this is what really angers me when I used to be a clinical director, clinical supervisor, and a CEO. I would see this, I would give the clinician one chance to fix it. And if they didn't fix it, they're fired. Done, because that's putting me in jeopardy. What they're doing, you'll see why. It puts me in jeopardy, puts the clinician in jeopardy, puts the center in jeopardy. Okay? Here's what I'm talking about. You got your biopsychosocial, you got your summary note, and at the end of the summary note are things that go on the treatment plan, and then you write the treatment plan. Now, you may sit there and say, well, yeah, that's what I'm supposed to do. Yeah, you are supposed to do that, but not that way. Okay? When you write a treatment plan, you should never do a treatment plan in isolation. In other words, you write the treatment plan, and then the patient comes in the next session, you say, here's your treatment plan, put it in front of them and say, okay, you need to sign it here, I'll sign it here, and the director signs it here, and the psychiatrist signs it there, and now we'll start treatment. Okay? You can do that. It's legal. But the problem is it's useless because a treatment plan is a contract. A treatment plan is a contract. And you, the client, and the center that you're working with. Okay? There are 4 signatures that go on the treatment plan: the patient's, yours, clinical supervisor or the director of the program, and the psychiatrist or psychologist, right? Whatever, again, the policies and procedures read. Those four signatures go on there. That becomes a legal and binding document. It is a contract. The treatment plan is a contract, not to be taken lightly. So what does that mean? It's a binding agreement. That's the definition, the legal definition of a contract. It's a legal and binding document. So whatever is in that contract, whatever you write down, the patient has to follow and has to complete and fulfill. Technically, and this usually doesn't happen, but technically, patient does not follow the treatment plan, that patient is in breach of contract and legally can be discharged from the program. Okay? Does that happen? Rarely. Most of the time, because patients are drug and alcohol patients, and they're a little bit different from psychotherapy patients. A lot of times we overlook that, which is a no-no. I would always sit there and tell my clinicians, what are you doing? How come you're not holding them to this? If the patient wasn't ready to do it, then why is it on the treatment plan? Well, because it was in the psychosocial, which brings me to another point. Okay. When you do your summary and when you do your psychosocial, you're going to come up with tons of problems. All right. I remember in my clinical years, I had a patient that had close to 30 difficulties, 30 issues that they were supposed to deal with in therapy. There is no way in creation, with the parameters of insurance companies, that you're going to work on 30 problems. This is why you don't do a treatment plan in isolation. Okay? So, how do you do a treatment plan? Well, you call the patient in, and it may take 2 sessions. You call the patient in, you sit there and say, well, this session and maybe the next one is going to be our treatment planning session. And then you describe what a treatment plan is, and the signatures, and what it means. And you tell the patient point blank again about confidentiality. You can tell me whatever you want. It stays here. Nobody can look in this chart, except those who you've signed off on already, and that's it. And then you sit there and you tell them that you and I, because it's a contract between you and me, the patient and the doctor, the patient and the we are going to work this treatment plan together, and you have to follow it. All right. And I'm going to hold you to this. Right? And you describe the company policy if they breach it, describe the company policy if they don't show up with sessions, all that stuff is done. And they have to understand it. And you document it in a clinical note. The session was a treatment planning session. During the session, therapist and patient talked about the parameters of the treatment plan, and we reviewed the clinical procedures for absences and dismissal in the program, and what happens when this patient gets a certain issue on the treatment plan. Sign it off. So you talk to the patient, you sit there and you say, thanks a lot for all the information in the biopsychosocial. You did a wonderful job. Thank you for your honesty. There's a lot of stuff here. And I want to just go over some of that stuff with you. Now, at that point, you may write down all of the issues that the patient has on a piece of paper and then hand it to them and sit there and say, this is some of the issues. These are the issues that I've picked up in your treatment plan. Let's go over them. Right? Are there any there after you go over them? Are there any there that you disagree with? What is it about them that you disagree with? Not why do you disagree with it? What is it about that you disagree with? Very important question. What is it? Who, what, when, where, and how? Do not ask a why question. I have, several people that sit there and say, "I'll always ask a why question because it gets a person to think." No, a why question is a closed question. Who, what, when, where, and how? That opens it up to discussion. What is it about that you didn't want to answer? Not why didn't you answer that? That can also be a threatening thing. I didn't answer because I didn't want to. Too personal. But what is it about that you didn't answer it. Can we talk about that a little bit? Yeah, well, it was a little bit uncomfortable for me. Oh, what made it uncomfortable? Do you mind? See what I'm doing? As opposed to, why didn't you answer that? Oh, so why not? Go ask an adolescent that. You know what you're going to get for an answer? Pause. Who, what, when, where, and how. So you present the issues in front of the patient, and you sit there and you tell the patient, which one of these or any of these do you not agree with? What is it about that that you don't agree? Now you may have to do a little um, what's the word I'm trying to do? Coercion in a nice way. Because usually when I get a patient like that says, I don't want to deal with this because this is one of my issues. Psychosocial it was, and now they're denying it. That's called resistance. Resistance can be a part of shame. It could be a part of denial. It could be something that is true, but they were so high. But even in that situation, they mentioned it in the psychosocial. So they may not realize that what they said was true and factual. That's why you want to pursue it, not just, this never happened to me. I don't know where that came from. Well, you said it in the psychosocial. Well, no, we'll come back to that. You make a mark of it. Once you figure out exactly, and that the patient's comfortable with it, and let's say there's 15 or 20 of them, right? You then ask the patient to prioritize. On this piece of paper that I gave you, you have a pencil? No, here, take this one. On a piece of paper, I'd like you to look at these and take a couple minutes, sit here and I want you to prioritize them from 1 to 15. Tell me, which one is the one you want to work with the most. That's number one that you think is going to be the most difficult, and go all the way down to number 15, which you think is the easiest. Or you can reverse it and say, start with number one with the easiest thing that you think you can work with, and go all the way down to 15, which is the hardest. I don't care which way you do it. Either way works. Okay. You then take that and look at it, take it from the patient. Okay. And then you mark down maybe the first 5. And you sit there and you say, okay, we're going to work on, I'm sorry, let me back up. You don't mark down the first 5. What you do is you take a look and you figure out with yourself how you numbered them. Did you start with the easiest or the hardest first? The easiest thing to work on or the hardest to work on? If you start with the hardest to work on, or the patient sits there and says, I want to work on this one first, what is it about that one that you want to work on? Well, because it's the hardest thing. For example, let's say a patient sits there and number 1 is abstinence, complete abstinence. And number 2 is staying away from my family members that drink. And the third one is stay away from people, places, and things. That's 1, 2, and 3. Abstinence, staying away from people in the family that drink, and staying away from people, places, and things. The first one is going to be the most difficult to deal with. Flush it out for now and tell the person, I hear you. You want complete abstinence. That's what we're going to work on. We're not going to work on that one in the first treatment plan. Now, I'm one that totally believes you want to go into recovery, complete abstinence. I believe in a complete abstinence model. That's just me personally. You may not, but I believe in a complete abstinence model. If you want to stay clean and sober, you got to stop using, right? And I'll do everything I can in the first few sessions to get you to stop using, even if it means putting you in a hospital and getting detox and then working you. But I don't believe in this slips and relapse and all this stuff. It's lazy work on the therapist. That's me personally. So I'm going to work against my model because it's a lot easier to work on your model. So you tell the patient, abstinence right now is a good thing, and I want you to strive for that. And that's going to be the key thing. So by the end of your treatment here, that's going to be your number one priority. And that's what you're going to take with you outside of treatment. Because during treatment, I want you to understand it's going to be very difficult for you. And sometimes things may happen. And I want you to use all of your tools. And your tools are going to start with this one here, staying away from people, places, and things. You can do that. You do. Great. You think it's going to be hard for you to do it? Good. How hard? Not very. What are you going to do? Now we start working on the treatment plan. Problem. Staying away from people, places, and things. Number one, problem, right? Second thing on the treatment plan, objective. Um, problem, objective, right? The objective is going to be a client will not hang around people that use substances, right? And then how are you going to do that? Your action steps. Client will get a sponsor within 30 days. Client will go to one meeting a day, 90 days, 90 meetings. Client will discuss any issues that come up with therapist. Number four, client will journalize feelings. And in the event that the client has difficulties, client will contact sponsor immediately. Document it in the journal, come to therapy on designated sessions and discuss issues with them, right? That's your action step. Your problem, your objective, your action step. Next thing is your time frame. How long is this going to be? Is it a long-term goal or a short-term goal? A long-term goal is usually 30 days or more. Short-term goal is usually a session, 10 days, 30 days max, right? Usually longer than 30 days are long-term goals. 90 days, that's a long-term goal, times 30 days is a short-term goal. And at the end of your treatment plan, you'll see something that says date achieved. Date achieved is very important because the date achieved on your treatment plan will tell you when you don't have to work on that anymore. Problem, objective, action steps, achievement date. Okay. Short-term, long-term goal. Then on some treatment plans, the client initials it, which I think is useless because the bottom of the treatment plan has got to sign it. Okay, so you have that. Now, one of the things that I want you to understand about treatment plans and writing a treatment plan. As I said, you have your problem, your objective, your action steps, your goals, your short term, long term, and the completion date. But how do you structure the treatment plan? How do you write these goals? How do you write these problems? Do not write a book. They're all one-liners, right? Maybe a couple lines. They have to be short and accurate. Everything has to be written into third person. Use quotes where necessary. All the goals and action steps have to be measurable, and I'll explain that in a second, reasonable, and obtainable. Okay? They must be from the biopsychosocial, not something that the patient just says, oh, and I want to work on this, and it's not in the biopsychosocial. Either that goes in the biopsychosocial, or you tell the patient, let's just work on these things in the biopsychosocial first, and when we're done, we'll create something else. Now, that doesn't mean that as time goes on, you can't add to the treatment plan. You can. Main elements of the treatment plan should be from the biopsychosocial. If something else comes up, yes, you're going to work on that. Yes, that will go in the treatment plan, but only after the material of the biopsychosocial is there. That could be like an ancillary one, maybe your third or fourth problem. But the main problems that you're going to be dealing with in the treatment plan are from the biopsychosocial. And I hope that's clear. And don't let anybody tell you differently. I don't care if you're licensed. I don't care who they are. No. And you stand to it, because I'm telling you, the insurance companies are going to take a look at that and sit there and say, what's this problem? That's not in the biopsychosocial. An inspector is going to come in and say, why'd you do this? That's not a psychosocial. Well, the patient brought it up in therapy, and I thought it was important. Well, it is important, but not as a preliminary thing. But you can always put an addendum in a biopsychosocial, and now you're covered. Oh, so it's an addendum in a biopsychosocial. I see. Okay, that makes sense. Okay. Right. If it isn't documented, it doesn't happen. Gavish? If it isn't documented, it doesn't happen. This is why I say everything that you do, document accurately. Use quotation marks. So let's look at this. Okay. So you've got your problem, your objective, your action steps, short-term, long-term goals, and date achieved. Let's look at each one of these and how you write them. So in the biopsychosocial, you see the person's got an addictions problem, right? Now, take your treatment plan and look at it. If it's a county treatment plan, you'll see on the top of the treatment plan numbers 1, 2, 3, 4, 5, 6, 7, 8, I think 9, 10. And each one, it will say they're number 1, drug and alcohol. Number 2, family. Number 3, legal. Number 4, social. Okay? That's very important, because that's the way your treatment plan is set up. Your first problem needs to be number 1, drug and alcohol. Every drug and alcohol issue goes there. Number 2, if number 2 is legal, right? Then you put number 2 down, literally the number 2, legal. And number 3, whatever it is. Now, you don't have to write down number 1, drug and alcohol, because drug and alcohol is number 1 on the top of the treatment plan. So when the supervisor or when the inspector looks at it, you're going to sit there and look at the treatment plan. Okay, number 1, drug and alcohol. Okay, so all of those things should be drug and alcohol. Number 2. Now they're done drug and alcohol. They're now on number 2. Number 2 is number 2, legal. Okay, good, legal. And all those things need to be legal. Does that make sense? All right. So your problem. Best way to write a problem on a treatment plan, use quotes from the patient. Why? Because the treatment plan is the patient's. It's not yours. This is why you dialogue when you're writing a treatment plan with the patient. What do you want to work on? I want to work on abstaining from cocaine. Well, how long have you been doing cocaine? Oh man, about 15 years. Number 1, boom. Client states, quote, I've been doing cocaine for 15 years, unquote. You don't have to put down cocaine issues. Client reports cocaine issues. Yeah, you can do that. That's fine. Client reports cocaine issues. But inspectors, supervisors like it better with direct quotes, because that shows the inspector, the insurance company, the supervisor, the director of the program that you're doing your job. Client states, quote, I have been doing cocaine for 15 years, unquote. Let me stop you there. Anything wrong with that? Well, if you remember, I said never write in the first person. Remember that? Always say this client or this clinician, except when you're quoting a client. On a treatment plan or in a progress note, if the client says something, well, I told him that was a bunch of crap. And you can put down there, Client during session presented with an angry affect. When discussing a drug dealer trying to sell him drugs, client said to drug dealer, quote, I think that's a bunch of crap, unquote. So long as you put the quotes in there, you put it in there. Even if the patient curses. I told the effing drug dealer to go F himself. That goes in quotes, not just F. You put the word in there, right? They put the word in there. That's fine. The only thing is, if you respond to it, you don't sit there and say, and this clinician told the client that that quote, that effing drug dealer should be shot, unquote. You can't do that. You've got to maintain your professionalism throughout the session. You know, if you're not sure what the client said, you sit there and say, well, let me just make sure I'm hearing you correctly. Are you saying that you had said this to the drug dealer? You know, shut the F up. And the client says, yeah, that's exactly what I told them. Well, what you write in your clinical note is after the quote, client stated, I told the drug dealer to shut the F up. You can write in there, therapist clarified statement between client and drug dealer. Client did in fact say what he said to the drug dealer, period. That's simple. All right. So in the problem section, you put down, quote, number one, quote, client states, quote, I have been using cocaine for 15 years, unquote. Objective. So tell me what you'd like to do with this throughout these sessions. Well, I'd like to learn how to stop so that I don't use anymore. Okay. Quote, client states, quote, I want to learn how to stop so I don't use anymore, unquote. Objective. It's not a problem. It's an objective. It's what you want to accomplish. Now you ask the question, how can we do this? And this is where you dialogue. Client may sit there and say, I'm just not going to use anymore. I'm not going to be around people playing. I'm not going to. A client is in front of you because they really have the will to change, hopefully, and they want to change. And they may be feeling good. They may be cleared up. Remember, they're addicts. They're addicted. They've changed their brain chemistry. They've changed their neurochemistry. They've changed their drive, their impulses. The intentions are good, but the impulse drive is greater than the intentions. Chances are, if they do something greater than what they say, remember, they write it down, they're contracted to it. And if you, as a therapist, as the clinician, feel that that's a little bit out of the ballpark for this individual, you tell them that. I'm sorry, wait a minute. That's where you want to get to. But let's do baby steps. Let's start with something that you can do, that you can accomplish. Doing cocaine for 15 years, place to do that. Okay. Do you have your drug dealer's telephone number in your cell phone? Yes. Okay. Can you erase it? Do you have it memorized? Well, most addicts do, but it may or may not. Okay. Can you erase it from your cell phone? That's an action step. Client will erase drug dealer's number from cell phone. Now, measurable. When are they going to do it? 24 hours. So client will erase drug dealer's telephone number from cell phone in 24 hours. That makes it measurable. That makes it reasonable. That makes it attainable. Okay. If you sit there and you say, client will abstain from all substances times 30 days. Well, it's measurable. It's not obtainable, possibly not, but it's not reasonable. Because basically what happens if 3 days down the road, the patient comes back and says, I relapsed. Again, though it doesn't happen, technically you can kick that person out of treatment. Why? They broke their contract. So that's not reasonable, nor is it obtainable. You see why if a patient sits there and says, "Oh, I'm just going to abstain from doing crack." Not yet. Maybe a month down the road at the next treatment plan, you can put that in there. Person's abstained for 30 days. Then you can put that in there. Patient will continue to abstain from substances times 30 days, but that's your second treatment plan. That's 30 days down the road. All right. Measurable, reasonable, obtainable. Those three things. Let's review this. Problem. Client states, quote, I've been doing cocaine for 15 years. Objective. Client states, quote, I would like to learn how to stop using cocaine and eventually never use again. Action steps. Now you have your discussion. Number one, I want you to go to 90 meetings in 90 days. I want you to come to therapy sessions weekly. I would like you to go to these groups, right? And you write this down, your action steps. One client will go to 90 meetings in 90 days. Client will continue in individual therapy sessions with the therapist on a weekly basis times 30 days. Client will go to relapse prevention groups at the center times 30 days, beginning 3/2/2021. Done. Just don't overwhelm it. You could write 15 or 20 things. Remember, this is your first treatment plan. Okay. And then once, let's say the first one is remove the telephone number from your cell phone. The patient comes back a week later and you ask them, have you removed the telephone number of your drug dealer from your cell phone? Yeah, I did. How did it feel? Really good. You talk about it, right? And if in fact the patient did remove it, then all the way at the end of the line where it says date achieved, right? Only that one, or removed cell phone number, you put down there the date achieved, 2/18/2021. Now, when you do your treatment plan for the next month, or whenever the next treatment plan is due, that goes off. You don't put that in there anymore because they achieved it, right? Then you keep doing that all the way down. So that's how you do your treatment plan. In the next Zoom presentation, I'm going to teach you how to do progress notes. That's going to be very critical to your writing. But right now, it was biopsychosocial and treatment plans. If you have any questions on this, again, review your materials. And please feel free to drop me at anthony.scuderi@intercoast.edu your questions, or put them in the forum, right? And address it. Well, Doc's Zoom, and I'm not really sure what he's talking about when he says talking to third person. What does that mean? Let's see if other students get it. I read them. If the other students get it and you got it, put in there, oh, thank you for your comment. I now understand that this is what it means. But don't just sit there and say, oh, thanks, I understand it. What do you understand? Right? In your forums, put down what you understand and why you understand it. Not just, oh, I enjoyed your comments. What did you enjoy about them? Right? Put that down. Take some time. Right? This is your career. This is your life. Because once you're done Intercoast and you're done with me, you're going to be on your own. And you've got a long career ahead of you, or a very painful one. So what you learn now and the pain that you go through now, when you get out to the clinic, ladies and gentlemen, you're going to be gangbusters if you do it right. If you take shortcuts, sorry, you're going to suck and you ain't going to last. And I hope you don't. Because if you're really going to take shortcuts, you're certainly not going to help your patient. So please take the time now. Learn this stuff. Ask me questions. That's what I'm here for. Have to give me a call on the phone and we'll Zoom. Drop me an email, your phone number, day and time that you want me to call you. Make sure you're there. I will call you by a computer. I'll set up a Zoom link and we'll do this. All right, so thank you. This ends our discussion on treatment plans, how to make them, and biopsychosocials. Catch you next time for when I teach you how to do progress notes. Have a great day. And this is Dr. Tony Scuderi saying thank you very much and hope to see you